Moving beyond bone-centered thinking, a new strategy for preventing crestal bone loss and peri-implantitis. When we place an implant, we tend to think in terms of bone. Is there enough height? Is there enough width? Where should the implant be positioned? And we work hard to position the implant where it can gain sufficient bone support. But bone is living tissue that never stops changing. Through continuous remodeling and turnover, an adult's entire skeleton is replaced with new bone roughly every 10 years. After a tooth is lost, alveolar bone resorption can be understood through Wolff's Law as a form of disuse atrophy. Load transferred through an implant addresses part of this, but it cannot restore the function of the periodontal ligament. The PDL is not merely a mechanical structure, it is a mechanosensory organ that regulates both vascular supply and bone formation. When the PDL is lost, the biologic regulation system that maintained alveolar bone homeostasis disappears along with it. Araujo and Lindy showed experimentally that ridge resorption after extraction occurs mainly along the buccal plate. This is not random. It is closely tied to the root's anatomical position before extraction. Using CBCT, Can and colleagues classified the sagittal root position of anterior teeth and found that more than 80% fell into class 1, where a thin cortical bundle bone on the labial side resorbs rapidly once the tooth is removed. To preserve this, immediate implant placement and socket preservation emerged. Some reports were encouraging, but European studies by Botticelli, Araujo, and others repeatedly showed that these techniques do not fundamentally prevent ridge alteration. This confirms something important. With or without an implant, alveolar bone is tooth-dependent, and its remodeling never stops. We often think of peri-implantitis as a bacterial infection, but bone remodels continuously, and over time, crestal bone loss can occur. Once the implant surface moves beyond its bony envelope and is exposed, the risk of bacterial colonization and contamination rises, and the resulting inflammation can progress to peri-implantitis. Eide and colleagues interpreted peri-implant bone loss not simply as infection, but as a process of biomechanical adaptation and structural remodeling. Abnormal mechanical coupling and load concentration at placement, combined with ongoing biologic remodeling, can accelerate surface exposure. However it arises, implant surface exposure is a critical starting point for increased peri-implantitis risk. And what about cases that required bone regeneration? Here, biology calls for even more caution. Huri Zhang and others reported that hard tissue augmentation can give clinically stable, predictable results. But that marginal bone loss can still occur. As Lutz and others note, most studies of buccal augmentation cover only 3 to 5 years, and data beyond 10 years remains limited. Even bone that looks successfully formed on a radiograph may change gradually through long-term remodeling. Regenerated bone follows the same biologic law as native bone, because bone is living tissue that is always changing. Crestal bone loss, then, is not a question of whether a technique succeeds, but a question of bone biology itself. So, what is important? What matters is not to change bone biology, but to understand it. The question now becomes how to maintain crestal bone stability for longer. To reduce bone loss, some early manufacturers proposed applying a laser-based microgroove to the implant collar to induce a Sharpie-like collagen fiber attachment. Indeed, Nevins and colleagues histologically reported that such a fiber attachment can form. However, a limitation was raised. In these attempts, the microgroove design was often located very close to the top of the fixture, posing a risk of fistula formation. In 2009, Thomas Linkevicius and his team proposed the zero bone loss concept, offering a new perspective on crestal bone stability. Through a series of human clinical studies, they reported that peri-implant soft tissue thickness is a key variable influencing crestal bone stability. In particular, when a vertical soft tissue dimension of about 4 millimeters or more is secured from the future gingival margin, marginal bone loss decreases and crestal bone stability becomes more predictable. It was later systematized through the Quintessence publication Zero Bone Loss Concepts and a growing body of clinical research, building the evidence for the importance of peri-implant soft tissue dimension. Even with continuous biologic remodeling, properly managing the peri-implant soft tissue environment can achieve more predictable crestal bone stability, and this is now repeatedly confirmed in the everyday practice of many clinicians. In other words, the zero bone loss concept is a biologically driven treatment concept that uses a sufficient soft tissue barrier to maintain crestal bone stability and protect the peri-implant tissue environment. But putting this into practice is harder than it sounds. In the posterior mandible, where gingival thickness is only about 1 millimeter, securing a 4 millimeter barrier may require placing the platform 3 millimeters or more subcrestally. That is logically possible, but difficult in practice. We have long grown comfortable with about 1 millimeter of subcrestal placement, the most comfortable position both surgically and prosthetically. Yet it often falls short of the biologic dimension the ZBLC concept demands. Is there a way to reach this goal more easily while keeping the clinician's familiar workflow? One approach is the BD cuff concept. Take a BD cuff implant with a 2 millimeter machined cuff placed in the usual 1 millimeter subcrestal position, 1 millimeter of gingival thickness, 1 millimeter of subcrestal placement, and the 2 millimeter machined cuff together form a biologic soft tissue barrier of about 4 millimeters, so the clinician can keep their existing surgical protocol while reaching the biologic objective of the zero bone loss concept more easily. The BD cuff can be a realistic solution that helps more clinicians implement this more consistently and predictably. Bone remodeling is an unchanging law of nature. Rather than fight bone biology, future implant therapy should work in harmony with it, minimizing crestal bone loss and implant surface exposure. ZBLC set this new standard, and the BD cuff can be a realistic strategy for realizing it. Through this, both clinicians and patients can enjoy a more satisfying outcome. The ultimate goal is a biologically stable peri-implant tissue environment.